So let's talk management now. So the go-to treatment is usually the Ochsner-Sharon regimen. It's a non-invasive management plan. And we go for this if the patient's condition is relatively satisfactory. The other reason is that the inflammatory process will have already localized, and so it may be difficult to localize the appendix, and an excessive attempt to localize it could actually lead to a fecal fistula being formed in an iatrogenic sense. Now, iatrogenic basically just means anything that happens because of treatment that the doctors are doing. And so what is the Ochsner-Sharon regimen? Well, to start with, it's a tricky name for one. But really what it is, I'm actually going to sort of go through it using a mnemonic that might help you. And the mnemonic is GP takes family care. Now, it sounds silly and it probably doesn't make much sense to you either, but I used this when I was in medical school. So a GP, a general practitioner, actually takes care of families. So that's just the gist of how I came up with the mnemonic. So in this, we are recording the general condition. We're recording the pulse every 4 hours, the temperature every 4 hours. We're maintaining fluid balance using IV fluids, using appropriate antibiotic therapy, and measuring the size of the mass. And you can actually, to make this easier, you can mark the abdomen with a marker and measure it regularly and see if the borders of the mass are going outside the original markings or getting smaller. So that's a good way of monitoring that. And also using a contrast-enhanced CT scan. And so this is useful because if you find an abscess on the CT scan, it can actually be drained then and there under CT guidance. Now, approximately 90% of patients resolve without any problems. And clinical improvement is usually evident within 24 to 48 hours. And usually by the 5th day or so, the desire for food, the pulse and the temperature, they return to normal, and the size then begins to decrease again. Failure to respond to the regimen can also raise suspicion of either a carcinoma or Crohn's disease. The need for an interval appendicectomy, which is an appendicectomy that you do after 6 to 8 weeks, that's debatable. Now, most people won't have recurrent appendicitis after this, and recently there's been a lot of talk about those who undergo the appendicectomies to have a higher incidence of an underlying neoplasm. However, that being said, there are indications for stopping the management, and of course then taking it to the operating theatre. So you have a rising pulse or increasing abdominal pain that's spreading all over the abdomen. You could have the size of the mass increasing or persistent vomiting. Now, these signs could indicate that there could be a collection of pus within the mass, and so it's really important to then order an ultrasound of the abdomen or a CT scan, and that can come in handy because then we can localize where to place a percutaneous drain if we need to drain the abscess. Now, these signs of deterioration could also indicate peritonitis, which is definitely an indication for a laparotomy. So in that case, you'd rush the patient up to the operating theatre. So that was all about appendicular masses, and I hope that you can say that you learned something new today. And don't forget to subscribe to sqadia.com to learn more.